Good morning, everyone, or afternoon. I just could not avoid putting the date in big because it's just a lot of twos. And then thinking about what we should focus on actually took me to something that we have been pondering a lot lately, which is the the double trigger, and as this pattern is very common. So let's talk a little bit about it and go through it. The disclosures, as usual, we discuss particulars of ventilator modes. We make no endorsements of any particular mode, manufacturer, or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. Uh, Here are my disclosures as well as Rob's. I would ask you just to keep your microphones muted. We may ask you to unmute yourself so that we can hear you as options come up. Well, use the chat function. That's really useful, and I'm monitoring it on the right all the time, and so it's very useful. And for all of those that are Cleveland Clinic employees, there's CMEs that you can use for your CREs and for your education. Okay, so We'll start basic. As I said, this is the day of multiple triggers or double trigger. So I'll ask any of our fellows if they're willing to give it a try, or ex-fellows, they're also welcome to give it a try. Have no fear. Any of our fellows? This is we're starting with the easy one. Ahmed, you want to give it a try?
Sure thing. So what's the tag? So I see a controlled flow waveform. I'm gonna go with VC,
Mm-hmm.
and I'm gonna go with CMV,
Mm-hmm.
and I'm gonna go with S. And then what is the load? Looks like let's see, there's evidence of PMUS on the pressure waveform and inspiration. And then expiration, kind of leaning a little bit towards resistance, but I think there's some PMUS as well, so maybe resistance slash PMUS. PV discordance trigger wise, so the second and third breath, the pattern of a machine triggered breath followed by a patient triggered makes me want to say this is an early trigger. And then I'm going to go with some work shifting and inspiration. Cycling seems to be normal. I don't see any evidence of early cycling in the expiratory flow. And then expiration, I'm going to say, for the most part, it's normal. Maybe some work in the third breath, but for the most part, I think it's normal.
Excellent. Ahmed, very straightforward case. I mean, the key here, as you recognize, I mean, and for this one, so that I put actually more cases than I usually put on one of these, but since it was two, I thought that we should review as many as we could. And so, indeed, it's volume control CMBS, and this is important to recognize. You highlight in this ventilator, sometimes you can put flow adaptation and it can change it to dual. But it is not. There's a high amount of PMOS in this breath, and there's no change in the flow waveform. I agree with you that there is evidence of PMOS on this waveform, and there's some hints towards it. Well, obviously, the big one over here. And then when you see these two, when I compare this one with this one, I would wonder if there was any PMOS on this one, but it also has one of the features that are often overlooked in a descending waveform. When you have a peak that is higher at the beginning of the breath, and then you go all the way down, and the end of the breath is here where there is no flow. That is actually the differential would be similar to what you had on the expiratory side, that there is high resistive load, and that or there may be PMOS. And so, because this moves in the same direction as the other one that you pointed out in the expiration, I would be aligned with you on thinking that probably this patient has a high resistive load as the main one, with obviously some PMOS in between. You read this wonderfully, a mandatory breath, and we know that because, I mean, this ventilator cheats for us. It makes it easy. So we know that this breath is flow triggered. This is the ventilator thought that this was the patient, and this is a mandatory, so rate-based trigger. And so this pattern is what we call early trigger, or which can have many etiologies, and we'll see. And one of them is this reverse triggering, which can, I mean, the physiology is still being delineated. You highlighted the presence of work shifting present over here, and some actually present in this breath over here. The cycle seems to be normal. I don't see any evidence of late or early cycles, so I agree with you there. And in expiration, I always have a little bit chance, but here the patient had double two breaths at the same time, and so actually you can see the tidal volume for this patient was closer to 500, and so essentially the patient got two breaths, one over the other, and that may take a longer time. I mean, he has a much more larger volume and resistance, so you can imagine what happens. Actually, if you look at the pressure that required for this breath, and then the next breath, it went higher because the lung is getting filled, the compliance starts to go down because it's over distended. And then look at even though the patient exhaled, the pressure that it requires for the next breath was higher because the patient had incomplete emptying at that period of time. Rob?
Yeah, I want to amplify what you said about the characteristics of a descending ramp flow waveform, particularly if you have a passive patient. The initial pressure is simply due to airway resistance, and the end inspiratory pressure is due to elastance. So the end inspiratory pressure is a good surrogate for plateau pressure without even doing an inspiratory hold, because you can see the flow is essentially zero at that point. Now, what this does is unmask the fact that this patient got a double tidal volume, even though it doesn't show that on the volume waveform because the ventilator resets every time flow crosses zero. Look what happened to the plateau pressure. It looks, to my eyes, about double. So that's the tidal pressure due to twice the tidal volume.
Excellent.
Which I think is well above 30, isn't it?
Yes. Yeah. It's close to 40, actually.
Yeah, so there you go.
So there's another. So in general, Ariel picked up on a good feature. The peak expiratory flow didn't increase much on this breath, which can be a sign of increased expiratory resistance or increased resistance, without a doubt. I don't remember, Aman, why this patient had increased resistance. This was one of those me walking around and then stopping, taking the picture, and then highlighting that. What I would say the key finding here is, so this double trigger that you're saying, we call it multiple trigger on our latest nomenclature, but what this one is due to what we would say early trigger. Now there's a couple of questions. Aman says no worries. Thank you, Aman. Michael Smith says his second breath reverse trigger or early cycle leading to double trigger. Excellent question, Mike. So we know that this is not early cycle because the first breath is a mandatory breath. So if you say, well, there was early cycle, but it didn't trigger the first breath. So to make it clear, we decided that if it's going to be called early cycle, the breath should be triggered by the patient. And you'll see a couple of examples about this. Very good. So the first case that we saw was early trigger. Great job. All righty. Here's another one. The intensity starts increasing. Anybody wants to jump into it? Any of the fellows? Aman, you want to give it a try?
Yeah, sure.
All right, thank you, man.
All right, so the tag is PCCSVS. It looks like, especially those tiny breaths, looks like flow cycles, so likely CSVS. The load during inspiration is all PMUS. And expiration looks maybe resistive. It's taking at least more than 2 seconds to come back, so not, maybe resistive. Let's see. PV discordance. So the trigger is maybe a little bit delayed. It's a pressure trigger. Can't see very well. It's not horrible, but maybe a little bit delayed. Inspiration, there's work shifting, but there's not awful, minimal. And cycle, so this looks like early cycle, especially in the first breath, is resulting in a double trigger. And even in the second breath, even though it's not resulting in a double trigger, you can see evidence of inspiratory PMUS right after the breath cycles on the flow waveform. So early and expiration is mostly passive. So yeah, I would adjust the cycle threshold here.
Yeah, very nice. This is another one in which so we're talking about early cycle, but it's not in a patient in which we're used to talk about, well, the neural time. So normally when we talk about early cycle leading to double trigger is because you feel that the time that you set for inspiration, so the I time, is shorter than the PMOS PMOS time, and so this is the patient effort time, and you set it low, and so it triggers another breath. But as you point out, this is pressure support, so the flow, the breath is patient triggered, and it's actually cycled by the patient by flow, and so what you have is it cycled off, and then the patient continued to have PMOS, and that PMOS, which you recognized over here, was enough on this breath to actually repressurize the system, and you can see actually this is a pressure trigger, and it repressurizes the system, and then the patient rapidly exhales out. So this is a situation that can happen on pressure support, as you're seeing, and it is, as you recognized in this case, because the cycle time, the expiratory cycle variable, which is the expiratory peak flow %, was set high enough, at least for this patient, that the patient was still having PMOS and was able to trigger. Rob?
Ariel asked whether this is actually auto mode.
No, it is not. At least in this ventilator, when it marks that it's going to be auto mode, it actually will say auto mode. I know that you probably are confused by the presence of this arrow back and forth, but it's just pointing out that is the apnea rescue breaths, Ariel.
Kind of an interesting thought.
Yeah.
Because because this was pressure triggered, if it happened to be set for flow trigger, would it actually have given you an early trigger? I mean, yeah, an early trigger, because it doesn't seem like the flow was enough to cause a trigger. I don't know, just thinking out loud.
I presume that's why he's on pressure trigger, or this patient is on patient trigger. That's my suspicion, is that this pattern was occurring frequently, and they tried to suppress it by using a pressure trigger, Rob.
Okay.
There is a question here. I would also call fail trigger after the third breath, where their early cycling and effort did not result in a breath. Yeah, that's a good question, Ahmed. So when we did the taxonomy, you obviously have to think about this, because you may start calling two things the same thing at the same time. So if the pattern that you see, the driving pattern that you see, is a early cycle. Even though these may look like a failed trigger, this would be an early cycle. So by taxonomy, that's how it would look. In terms of the trigger, Aman, I think that it actually looks pretty decent, very nice. Not I mean, it pressurizes right along. If anything, I mean, it may be hidden by the gain and the scale on the pressure waveform, but I would call it essentially normal. I agree with your resistive load, at least by the time that it's getting it to return to baseline, as you're seeing there. I agree that there is some work shifting. It's not severe, and the rest of your reading is right on. Rob, any other comments?
Nope.
So this is a double trigger actually on pressure support. That's the second cause, early cycle due to an inappropriately set. Now, I thought that it would be useful for us to see. This is a beautiful article that Piquillot published in Intensive Care Medicine in 2011, and I'll show you another image of it. But I wanted to highlight what we just see here. So this is again a patient on PCCSBS or pressure support that has double triggering, and the difference of the image that I showed you is that this one has, again, the airway pressure, the flow, and it has the electrical activity of the diaphragm with the NAVA catheter. And what you see here is a double trigger on this patient, again, in which you have the flow with evidence of PMOS. There's the cycle threshold is met, but the patient, as you can see on this waveform, even though there was a little pause, there continues to be continues to be PMOS, and it triggers the next breath as such. So an early cycle, and this is even further evidence of that, just because you have the EAD, the electrical activity of the diaphragm, that helps you see when there was activation. If you had a esophageal catheter, you could also potentially see this. You would be able to see this type of interaction. So that just to prove there this type of double triggering. Questions, comments, Rob?
Just want to make a quick comment.
Yes, Aman.
Yeah, so I think we've seen it once together as well, but I've sometimes seen that in some patients you reduce the threshold all the way down to 1%, and you still see some evidence of early cycling.
Yep.
It's not that common, but I thought about it a little bit, and I think it's more likely in patients who have very stiff lungs and very short time constant, that the equilibration of inspiratory flow happens pretty quickly while their PMOS is still ongoing. So in those situations, there's not much you can do. I mean, in this case, there's still room to go based on the waveform, but sometimes you just can't fix it.
Absolutely. Actually, we have several examples of doing that. I completely agree with you, Aman. Excellent observation. And that occurs often in our ECMO patients. We've seen that. We have several images of that. Very good. Rob, any other comments?
Nope.
All right, so we move to the next one. Anybody wants to try this one? Any of our fellows wants to give it a trial? Mike, you want to give it a try?
I was just about to press the button, so
I love it.
Yeah, so I guess I get it. So the tag to me looks like to be VCC-MVS.
Mhm.
The load, at least in the first breath there, it's the inspiratory load is PMOS, and I know it seems to be cut off because that seems to be the reading, but at least compared to what the previous breath, I would say that the expiratory load is either going to be PMOS or resistive, but my guess is probably leaning more towards resistive. As far as the discordance, at least the first trigger seems to be a normal trigger, although I guess you're going to say this is going to be at least an early cycle, at least in that, I guess technically a double trigger, but at least in that first breath is an early cycle. And then inspiration is severe work shifting. And then, like I said, expiration, either this expiratory work or resistive load.
Okay. Really good. Excellent job, Mike, reading this again. This is another example, the same ventilator without flow adaptation, in which the tag is volume control CMBS. And you're right. I mean, this is a horrendous amount of PMOS. Essentially, the patient is doing all the effort, and you can see it goes from wherever. I mean, this is 35. Let's say that this is 15 of PEEP. It goes all the way down and actually goes negative under it. So it's pulling like there was no tomorrow. And that pool actually generates these double two breaths being triggered one after the other. You have one breath that looks passive, actually, this one over here. And if you would see this based on what Rob just commented, in which there is, this is a descending ramp, and although it doesn't go down to zero, this point over here is more related to elastance, and the peak over here is more related to resistance. So I would say that just based on this waveform, it could be elastic elastance, but I don't have enough information. It seems that it's going down with time. So I'm with you. The main feature is that massive amount of PMOS that you see down here. I mean, so the trigger is normal. It pressurizes right around. It's a flow trigger. Inspiration has severe work shifting, as we said. And then this is a classic case of early cycle. And actually, the cool, not cool thing about it, about this image, is that essentially you have a pressure tracing that tells you the size of the PMOS. I mean, the patient is doing so much that this is how your esophageal pressure probably should look. And the patient gets those two breaths. And so if you imagine that this is the whole inspiratory time, probably all the way over here, and the time that we set for inspiration with the ventilator so was this long, so you can now see the presence of early cycle, so perfectly well read. And there's I agree with you, there's some evidence of PMOS over here on the patient. And the scary thing, as you have recognized again, is that in this patient was getting around close to 500 of tidal volume. So the patient got, actually, you can see no expiration at all. There's no flow coming out during this period of time. So the patient got these two tidal volumes, one on top of the other. And then as the patient is exhaling, actually, you can see this is from 500. The scale kept going all the way down, but it got lost because it will not adjust that. So this is another type. This is the type of early cycle that occurred in volume control. So you can rapidly see a little difference between this early cycle and this early cycle, even though both have double trigger. The consequences of this is volutrauma, right? The patient is getting two tidal breaths. The consequences of this, I mean, this is the extra tidal volume that the patient got. You can see it here. It's a tiny little small thing, nothing. So the consequences of this double trigger may be different than the consequences of the other in terms of lung injury. Thoughts? Rob?
We've talked about this before, but when people set a descending ramp flow waveform, I can't see any reason not to let the flow go down to zero. It's set above zero here, like, I don't know, what, 10 or 20% or something like that. But the reason to let it go to zero is then your end inspiratory pressure is a pretty close estimate of the plateau pressure. I don't see what advantage you get by setting it this way.
Exactly. I don't either. There's not a good explanation in my book. Ariel points out, and rightfully so, that there is no good peak flow here, so it doesn't look like that, and that makes him think that there was still some amount of PMOS occurring at the time of this. And my organization may not be perfect. Actually, it does make sense, because even with those two breaths, you can see that there was not even a rise on the pressure, so there was still some PMOS when the second breath cycled. Very good, Mike. All righty. Any other comment from the team? There's a question, makes sense to me. Based on the second waveform, was this patient was completely asynchronous over time to the point where we would see reverse triggering based on the second waveform? Which second wave, Mike? I'm confused. Explain.
I'm sorry, I worded that poorly.
Yes.
Because I essentially I see someone taking a like 1,000 or probably even greater tidal volume breath, and then was immediately followed by a passive breath, or by a passive, where by breath where he's completely passive. So it seems like he's taking big gulping breaths at large intervals. So I just wanted to get a sense of what this waveform would look like, over a period of several breaths, or a period of like 15 or 20 seconds, as opposed to the small snapshot that we have here.
So if there were more of these?
Correct. Yeah.
Yeah, actually that's a great point. One of the challenges, and recently they have been, now that they can analyze several thousand breaths and come out, there's these comments about clustering, and these may be related to events that occur in the care of the patient. So what I can tell you, this is one moment, and perhaps that was because somebody came and woke him up, or did a maneuver. The patient had a large breath, and that's it. Or it may be that the patient is coming out of sedation, and you have this is just one of 50 that the patient is having in a minute, right? So this could be the intensity of what you're seeing and the frequency of what it's seeing will also have an impact on the outcomes of the patient. So good points, Mike.
It would be good to follow that up with a screenshot of the trend screen.
Very good. So here's another one. Is there one of our fellows that wants to read this one? You can see the topic is very similar. Going down the list. Russell, are you interested? Give it a try.
Dr. Mireles, this is Gaurav here.
Okay, Gaurav, hit it.
So the tag seems to be PC CMVS.
Mm-hmm.
The load is, what I see, some PMAS. No, maybe not. I would say let's go with resistive load in inspiration. Expiration 2, let's go with resistive load. Right away in the first breath, you do see some PV discordance. Actually, I'm not really sure. Like the first breath, I see there is some PMAS. So can we change the inspiratory to PMAS, I guess? Sorry. I think right in the first breath, you see some PV discordance. And at the end of inspiration, when the flow is trying to cycle off the breath, the patient, I see some like a PMAS effort and a breath is triggered. So I would say early trigger, at least in the first breath. Inspiration, I would say word shifting. Normal cycle.
I couldn't hear you. Sorry.
Normal cycling.
Okay.
I mean, the first breath, I'm calling it as early trigger, but the second breath, I feel like the cycle is normal. And then there is some expiratory work.
I could not hear you.
There is some expiratory work.
Okay.
You see, it's not like a nice decay waveform.
All right. So let's go over it. Thank you, Gaurav, for jumping in. So indeed, it's pressure control. We're controlling the pressure. So during the breath, and all breaths are mandatory. Actually, you can see some features of that in that the cycle time, and you can see it over here and over here, is the cycle is mandatory by the ventilator, and it's a set point targeting scheme. In terms of PMOS, so you can see over here, this is a patient trigger breath, right? You see that, Gaurav? It's a flow trigger, and the second breath, there's this very small exhalation, and there's immediately another one. So this is a double trigger pattern, and what you see here is the first breath, second breath, so it triggers both. And in the next one, this actually is a mandatory breath. There's no trigger by the ventilator, and it's cycled by the machine. And the flow just goes straight down instead of nicely as we would want it to look, like that. And we can talk about that one in a second. And then the expiratory time, I mean, it takes it around 2 seconds to exhale all this tidal volume. On the next one is probably around 1.5. But there's some evidence of PMOS in both of in this one. In this one, not as much. I had some trouble reading this one, and I was thinking that there may be some PMOS hidden in these two efforts. So I would stick with PMOS for now. I would have to get a little bit more view into it, and perhaps some resistive load as you read over here. There's a question that asks, are you sure that the first breath was triggered by the patient? Yes, Ariel, at least the machine is saying that it's triggered by the patient. So if the first breath is triggered by the patient, as you see here, then the question is, and it's followed immediately by another breath. The question is this a this is a normal trigger, actually. It's triggered by the ventilator. And so if this, rather than an early, because it's predated by a patient-triggered breath. There's some work shifting, as you pointed out, Gaurav, and the cycle, I think, at least on this breath over here, seems to be early. Now, you could argue with me that there is, if this is PMOS, why there's a later increasing flow later on these patients. So at least by taxonomy, you would say, well, this breath was triggered by the patient, and the next one. So this may be a bimodal effort on this patient. We see those sometimes in which you don't get a single activation of the diaphragm and then it stops it. There may be another effort while they're doing this. And so that's what I would read it as probably an early cycle, Gaurav, because it starts with a patient and it finishes with a patient. Without an esophageal balloon or an electrical activity of the diaphragm, that's as far as I can get on this. And then in terms of expiration, I talked about this. I would point out that in this one, as you can see, there's evidence of effort. There's no question that all of this is effort over here of the patient. It triggers the next breath. And in the next breath, you can see that the patient doesn't get the same amount on the first one, that gets less tidal volume. However, now the patient is trying to exhale with the pressure going up. Actually, you can see that the ventilator detects that, and the pressure rises, and the flow. This ventilator tries to close the valve for an amount of time, so the pressure will go up. And when you see that, there's some concern. Although I have not seen any clear evidence of models, is that there may be what they call eccentric contraction of the diaphragm that may lead to injury. And so I would just put it there as there's potential concern. There is less risk of polytrauma to a certain degree, I guess, because you're not going to get at least the 2 double doses, and if it's short-lived, you may get actually no extra volume because it's limited by the compliance and resistance of the lung, but you may get some ill effects on the diaphragm. And so the reason why I put this here, even though this is an early cycle case, is because the difference between volume control, pressure support, and volume control, those 3 cases of early cycle may not have the same effect on the diaphragm, the lungs, and whatnot. Rob?
Nothing to add.
Okay.
No, that's good.
All righty. I see a lot of comments. Let me go back. Are we 100%? I answered that one. Building on the first question, where there is 2 phenomena were actually driven by only one. So the one that drives is the one that you use. It's And then I asked that because I have seen RT caused by auto trigger. RT, so it would not be RT. It all depends on. That's why the RT is a tricky. I have issues with that name because it implies a phenomenon. What you're talking is you have seen double trigger, so that pattern. As the message over here is that there's patterns like double trigger that have multiple causes. One of them is early trigger, one of them is early cycle, and we're gonna see, and as you point out, there's others that it's false triggering, and I'll show one in a second. Can see brief rise in flow before the first exhalation, then the second breath. Yes, you're right, Doug. Yes, and Amand highlights that there's also the drop in pressure. So I think that we're all seeing the same things, the increasing flow, the drop in pressure. So very good. Excellent discussion. Any other points, Rob? We're happy?
No, that's good.
All righty. Good. We're breaking records here. Oh, this is a good one. This is a different etiology of double trigger. Anybody wants to give it a try of the fellows? Samid, are you in for one?
Yeah, I can give it a shot.
Thank you, mate.
So the control variable appears to be pressure because I don't see a strict flow control. I mean, also I can see it on top, so I have to say that this is a type of IMV type 2, where spontaneous breaths are going to suppress the mandatory breaths.
Mm-hmm.
And I think it's going to be adaptive for the PRVC and also adaptive for the VS, so IMV2AA. And in terms of the load, I see that there's some, in the beginning, before anything, there's either it's an expiratory hold that's somebody is pausing, so I don't know what's happening there. But at least the breath I see a lot of PMUS in inspiration, and the expiration doesn't seem to be a fair decay, so I will say PMUS as the primitive load. In terms of PV discordance, I think there is a pressure trigger. I mean, correct me if I'm not seeing the color change correctly, but I think the machine is set to a pressure trigger.
You're correct.
And what seems to be that there is a patient effort detected, there was a flow delivered and maybe cycled by time, that another patient effort is there. So I would say it's either, it's difficult to say because I want to say early cycle, but the flow never cycled off. So it could be, for some reason, I am tempted to say it's a false or something causing a false trigger. Like the first breath is, there's patient effort, the pressure went down, flow was delivered, and then something happened, and that caused a drop in pressure and allowed for another breath. So I can be absolutely wrong, but I think it's a false trigger, the second one. In inspiration, I think there is work shifting. There could be some early cycling, I think, but since I stuck with the false trigger, I don't know. Maybe some other early cycling. I can't be certain. And expiration, there is work shifting.
Really good, Samir. Great work reading this. So this one, Ariel, you were asking me earlier about the auto mode, so you can see now how it reads auto mode on top of it. As Samit said, it's IMB type 2, meaning that it suppresses breaths whenever there's spontaneous breaths, but this is adaptive. And adaptive targeting means in this circumstance that the mode is actually volume support. And so if the patient is doing a spontaneous effort, and you can see how under these circumstances, this is the PEEP, essentially the pressure at the end of expiration. When the patient gives a breath, it stays at the same exact level. Actually, the only moment that it goes up is when the patient is actively exhaling. So this patient is, although he's on volume support and the machine should be giving some inspiratory pressure, it's not giving anything because the patient is way above the tidal volume target that it has been set, and that's why I put it down here. You see that I put 400. The patient is getting close to 800 tidal volume. So that's adaptive, and that's the importance of knowing the targeting scheme, is that in these circumstances, for a patient with high work of breathing, you will get nothing in terms from the ventilator. So this patient would be probably better under CPAP or pressure support than this breath in terms of support. You read this very well. This is pure PMOS. Instead of being a nice decay or a nice decay on the both breaths, this is all PMOS. And during expiration, you're right. At least on this waveform, you can see evidence of effort there. And so I agree completely with you, Samit. Good job there. Now let's think a little bit about this. So this is a patient-triggered breath, and we know that because there's a change in color here, and we see the drop in pressure, and we see the next breath again with the same one. And even though a couple of you identify the cardiac oscillations, and there's a lot. I mean, they're pretty marked on this patient. Even though the gain is high, you can see how much oscillations are from the heart of this patient. It never does as much a drop in the pressure on this patient, and so this moves against this being a false trigger. And actually would say the triggers are, if anything, late on the second one, but I think it's just the effort. So I will call it normal trigger. I agree with you that there's work shifting. As you pointed out, there's no effort from the machine on the patient. The patient is doing all the work. And this is another case in which this is patient trigger, this is patient trigger. So this is a type of early cycle, but it's not the early cycle as we normally call it. And that's the important thing here. There's different types of early cycle that in this case, the algorithm that the people that created this ventilator, the servo, they put out an algorithm that said, if you reach 1.5 times the tidal volume that is set, the machine will cycle off. And so it cycles off early by the algorithm, and then the patient continues to do effort and gets the rest of the breath, as you can see, which doesn't make any sense on any book. I mean, I don't know why we're doing that. And it happens both with pre-RBC and volume support in this particular ventilator. And then I agree completely with you with expiratory work here. So even though this is early cycle leading to double triggering, you can see that the cause is different, and the type of probably injury that the patient may have may be different in terms of what they get. There's a couple of comments. Ariel says the tag appropriately. Doug, you're right, those are cardiac oscillations. And yes, the pressure waveform looks like CPAP. Rob, comments?
Oh, that's good.
So again, this is another type, and perhaps in a patient like this with this amount of tidal, actually you can see that it's coming from another breath over here with a very large amount of tidal volume that is coming on the prior one. So I will just put it there that there's a value proposition on which one of the two double triggerings is worse. This is another type of double trigger. And this one we have talked a little bit, but I would like to hear from the team what they think it is. So who wants to give it a try to this one? Any of the fellows? We're almost there. There's two more. Sal, you want to give it a try? I know you're in the middle of the unit, so you may have an excuse to say no.
I'll give it a try.
Thank you.
All right, I think I need to step out from this room. Let's see.
All right, what's the tag?
So the tag is, this looks like a volume control CMV S. It looks like a ramped waveform. In terms of the inspiratory load, it rises pretty sharply. So I would guess resistive inspiratory and also resistive expiratory. Looks like a long time constant. And then in terms of PV discordance, looking at the triggering, it looks like there is a mandatory, the first breath is a patient, looks like a patient triggered breath, but it actually looks like these are like couplets. And there is a mandatory breath that is then followed by a patient triggered breath, supposedly. So I think there's some, looks like a false trigger, followed by a patient trigger, which would be a double trigger in this situation. And then on inspiration, I don't see much work shifting. I imagine much of that is related to the resistive load, the pressure. And then on expiration, or sorry, on cycling, I don't see any cycle desynchrony. I think those are just artifact from the high resistance of the patient's respiratory system. And then cycling wise, it's a very long time constant, but I don't see any PMUS there. Looks normal to me.
Really, Sal, thank you for speaking up. Excellent job. Excellent job. You are absolutely correct. That's the tag BCCMBS. The load is massively resistive, and the thoughts for that you identify them. The first one is you can see a very high peak over here, and this is the end pressure, and it ends at the end of a breath. And actually, a cool thing, this is exactly what Rob was talking about. You see the second where it ends over here, it goes up, and that's because this patient got 2 breaths on top of it. So the pressure is just, the plateau keeps going up because this patient got double the tidal volume under this circumstance. There's another feature that now I recognize on this ventilator more often, which is this reverberance that occurs over here, that is part of their algorithm to try to get the pressure back to resistance. And this is a very, this is consistent with increased resistance on this ventilator, these types of oscillations that we see. I think in terms of trigger, you hit it on the nose. The first one's mandatory. So this pattern over here, mandatory, and then patient, we would normally call this one an early trigger, but this is not. This is a false one. This is a false trigger in which the breath generated the trigger of a flow cycle, and it led it all the way up, and we don't see any evidence of PMOS otherwise on this patient. Yeah, thank you, Aman. This is a time constant valve controller. And actually, sometimes you may get even confused because you will see the drop on pressure, but that is part of that algorithm of that time constant valve controller to try to get the flow there, and you will see those oscillations. And the key here is that you don't see any evidence of PMOS, as you really well identified. There's no evidence of PMOS here, and no evidence of PMOS here on this volume controlled breath. So there's no evidence of PMOS in inspiration. The cycle, as you pointed, this is an artifact, and so it's completely normal. And expiration doesn't show, again, any evidence of PMOS on this very high resistive patient. Actually, this patient was paralyzed of all things and continued to do this. And you can imagine the puzzling that it generates at the bedside, saying, is this paralytic not working? So this is another cause, the third cause. So we have talked about early trigger. We have talked about early cycle. with different variations of early cycle. And we have talked about now false trigger as a cause of this pattern, double trigger. So let's look at the comments. False trigger caused by elastic recall of circuit. P plat is high as resistance. Yes, Ariel. This disagree is not trivial. I agree. This is actually pretty challenging because now you have a patient with increased resistance in which it's getting double the dose. So you're generating further air trapping on that patient, and so the pressures inside the thorax in a patient that gets double the dose is not trivial at all. The question of Samir, is this because the time constant valve control causing initial opening to keep resistance low? Yeah, it tries to drop the pressure so that you get to PEEP as fast as you can. That's right. Very good. And the last one, we're going to achieve this, I know. I put this one because this one, I'll read it really fast because we're about to end. But this is also from that PKO ICM paper. And lately, I've been musing about NAVA, and today I know Krister is going to be talking to us later today, and it's really exciting about it. But in NAVA, the tag is pressure control CSBR, meaning it's proportional to the EADA, so the electrical activity of the diaphragm. And so during inspiration, we see essentially PMOS on this waveform. And during expiration, actually, it's returning to baseline really fast on this patient in particular. And so I would say that the load is likely to be elastic on this case just because the flow returns to baseline fast, rapidly. The trigger seems to be normal. I mean, you don't see any delay on the trigger, and we know that the trigger is actually the electrical activity of the diaphragm. And so I'm going to call this normal. And then during inspiration, actually, this is the anti-work shifting mode, right? Because it's proportional. So if the patient does effort, the machine will deliver effort proportional to however you set the NAVA level. So I would call this actually a normal interaction between the ventilator and the patient. And then the cycling, and here's the trick here. If you see the cycling with whatever the ventilator is doing, you would say that the cycling is actually normal in this breath and in this breath. But if you look at this one, the ventilator cycled the breath according to the electrical activity of the diaphragm. And sometimes the electrical activity of the diaphragm may have this biphasic look or other types of look that may falsely activate, make the match the trigger criteria, which is, and so create an early cycle of sorts, which, however, the PMOS continues to go. You see how it activates again, and so you pressurize again, a little bit of flow, a little bit pressure, and a little bit of flow, and the patient ends and then exhales, and so the exhalation is normal. So this is another type of double trigger, and when you use these definitions of what a double trigger is for the synchrony index and whatnot that lumps everything together, you may end up with, if you read along, you're going to see that there's a higher incidence of double trigger in NAVA. And so I would pose again that in these circumstances in which it's cycling early because of the biphasic form of these, that the effect, just as we saw on pressure support and in other modes, is not necessarily the same trigger, the same effect of double trigger under those circumstances. So let's see if there is any. There's a good question here. Rob asks if Hamilton IntelliSync avoids this. I don't know. I mean, I get it would be an interesting thing to look. How much does it avoid double triggering? Is there an implication of this biphasic nerve impulse? Is this related to sedation? I don't know, MHK. And actually, we're going to talk with Krister in a little bit, and I'm certain to ask him that question. So with this, I'm going to move on to, here's the CME for all of those that work at CCF and our RTs and staff that are listening to this. Please make use of it because we really want to improve that. So here's the CME code. And please just recall to send us your waveforms. We really learned a lot from them, and we will bring them up and always give you credit for where your credit is due. Rob, any comments about all of this and the biphasic nerve impulse?
No, it's great. It was a great presentation today.
Any other questions or thoughts? So I hope that this helps you recognize this is a pattern. It's not a synchrony per se, and it has multiple etiologies. And it depends in what mode you use it, how much injury you're going to create. And with that, I thank you. Hope you have a great day, and see you in our next VentRounds in 2 weeks. Bye-bye.